So persistent wound discharge. I know when Mahesh gave me this topic, the first thought process which went into my mind, I shared with him. What will I actually speak on it? It's just a discharge and you have to do something. But then I went into the literature and what I realized, the risk to PGI, devastating complication, we all know there will be revision surgeries, dramatic morbidity, mortality. What goes into a patient's mind when a wound starts discharging is actually different from what goes into a surgeon's mind. Second post-operative day, you have a discharging wound, you have some crazy thoughts going into your mind. Incidence 0.2 to 21% and lack of agreement on the definition. A definition for you for PGI wound discharge would be different from mine. So that is what the literature was full of it. I'll just go through a couple of slides to tell you that the rate of PGI in wounds that persistently drain post-operatively has been reported in various studies to range from 1.3 to up to 50%. The Patel et al. They showed that each extra day of persistent wound discharge carried an additional 42% risk of wound infections in TKA and 29% risk of wound infections in THA. And much focus is now devoted to the prevention of PGI, recognition and treatment of the persistent wound discharge, and this should be the first logical step in preventing PGI. However, evidence-based clinical guidelines for the diagnosis and treatment are still lacking. There is increased risk of PGI, readmissions, prolonged hospital stay, reoperations, and higher healthcare costs with wound complications. Gallet et al. 6% increased cumulative risk of PGI in patients with wound complications. Gallet again came back and said 10.5% risk of PGI, 12.5% risk of major reoperation in 2 years in patients with surgery for post-operative hematomas. Wound-related issues also lead to worse functional outcome, residual pain which is similar to post-infectious group. So by definition, this is a paper from Parvazi. Wherever you go, you find Parvezi sitting somewhere or the other with infections. And so many papers, it has been suggested that wound drainage from 2 to 9 days post-operatively is persistent. A wound is said to be actively draining if an area of the wound dressing of more than 2 by 2 centimeter is wet beyond 72 hours post-operatively. This was from the first international consensus meeting in 2013. Then General Assembly, other international consensus and other definitions came up. Drainage for more than 48 hours, soaking through the dressing. Continued drainage beyond day 4 post-operatively. Drainage beyond 2 days post-operatively for non-infected cases and 5.5 days post-operatively for infected cases. So there was no general consensus. Then CRP, a maximum value within 2 to 3 days is reached. The CRP normalizes in 2 to 8 weeks, even in rheumatoid arthritic patients. And you suspect infection with persistent wound discharge if the CRP starts to increase post 72 hours or is elevated post 7 days. So CRP became the major monitoring factor. And this is, see what happens. Drainage within the first 72 hours, serous and serosanguinous is the usual case. This is physiological, non-infectious. But drainage continuing after 72 hours, it could be fat necrosis. It could be a poor hemostasis. It could be a dissolving hematoma. Or it could be a fluid from the deep capsular defect. This is one of my case. This is what we saw on day 2. Opened the dressing and this is how the knee looked. This was a hematoma. We actually aspirated and she settled in 5 to 7 days. But we have to be in faster, quicker, and we as a protocol, we always put an ultrasound probe there as well. This is again one of my case. One of this in the morning, this was discussion about old implants, removal and retrieval of implants. This was a patient with screws 40 years back. Medial side, there was scarring. Just to get to those screws so that I can put in a keel. And I remember what Dr. Pachore said in the morning, don't remove those implants. So we only wanted to remove one screw so that we can put in a keel. But to reach that screw, the old Phillips head screws buried inside, we had to elevate a medial scar. It was, the skin was adherent there. So we actually, when we elevated, this is what we saw in the post-operative period. We put in a vac, it did not settle down. We went in with our plastic surgeon and we can see there was a posterior capsular defect just to get those screw out from the behind. And the knee was just continuously draining. So it was not infection. The plastic surgeons gave us a flap cover. We closed the posterior capsule. We had to close. So we put in 4 anchors all across on the medial border and then tied them down with anchors. So what happens in persistent wound discharge? The natural barrier of the skin is bypassed. Majority will heal physiologically. If not, then it provides a retrograde pathway for microbes leading to persistent joint infection. Here, how to manage if you have a wound discharge. The 2013 International Consensus Meeting strongly advised strict monitoring of continued wound drainage persisting longer than 72 hours. Surgical management should be considered when it continues for more than 5 to 7 days after initial surgery, despite the non-surgical management. Early surgical exploration and debridement within 5 to 7 days post-operatively has been shown to resolve this wound discharge in 76% of cases, and it has been noted that delaying debridement may result in PJI. Surgical treatment is not a minor surgery, may potentiate the risk of future morbidity and PJI. To treat it as stage 1, joint aspiration is recommended prior to skin incision of the surgical debridement. If a wound has been deemed problematic, a minimum of superficial exploration and debridement and hematoma evacuation should be performed, and multiple intraoperative samples again need to be stained and cultured for an extended culture of 14 days. Patel et al. Came up each day beyond 5 days increased the risk of PJI. Saleh et al. Said 12.7 times increased risk of PJI. And if a wound, as I just said, I won't want to, but if the joint capsule appears to be compromised intraoperatively and deep infection is suspected, then proceed like a dare. And empiric antibiotics are started after the procedure and de-escalated where appropriate as soon as the microbiology results are available. Then how do you do that? In early cases, absorbent dressings, pressure bandage. Hip cases, you can think of a spica dressing, joint immobilization, and avoid therapies. So best for us, we decide is we just stop them from doing any physiotherapy for next 48 hours, give pressure bandage. Most of them do settle down, and bed rest, braces, and silver impregnated dressings, and then NPVT. And then correct the anticoagulation. So most of the times we actually think of giving them the DVT pumps, but we'd stop the Clexane there. And we have seen that has worked. Anemia correction, glucose level monitoring, and correcting their nutrition levels. And INR more than 1.5 can increase the risk of PJI. Open debridement and thorough lavage with 9 liters of fluid, dilute with iodine or chlorhexidine, change the modular components, meticulous closure, and send samples. ICM also divided this wound discharge into 4 categories. I'm over, last slide. Limited, when only a stripe of blood is seen. Moderate, when more than 2 by 2 centimeters. Excessive, 1 dressing change per day. And if you have to do more than 1 dressing, then it is massive. Cat 4. And they gave us this big chart which says how to proceed with Cat 1, Cat 2, Cat 3, and Cat 4. And just to summarize this, these are just the risk factors for an unsuccessful dare. I won't go much into the detail, but it's a very interesting paper that can be taken up. So the take-home message should be, the goal in managing persistent wound discharge is to minimize the time to achieve a dry healed wound. Emphasis should be placed on prevention of this discharge by identifying and addressing the previously discussed risk factors pre-operatively to optimize the patient's condition. Most important, I feel, is the nutritional status and diabetes in our patients. And once the persistent wound discharge is identified, there should not be a time delay in utilizing both non-surgical and surgical treatment options to ultimately prevent the consequence and the need for revision surgery. Thank you so much.